Okay, it looks like it's 1 o'clock on my iPhone, so I'm going to go ahead and kick us off. Thank you everyone for being here, and I'm going to try to not take up too much time because I think we have some great panelists. We have our bios that are all in the presentation, so I won't go through those. But let me start by saying that the view of drug use as a moral failing has long pervaded and steered the criminal justice system, ensuring harsh punishments for individuals and communities. The emphasis on using the criminal justice system to treat a public health issue additionally diverts critical funding needed for evidence-based substance use disorder interventions. The intended deterrence of drug use through swift, severe, and certain punishment has resulted in damage to public health and the continuation of policing strategies that reinforce structural racism. It has, in particular in America, undermined civil liberties, together with the very legitimacy of law enforcement and the criminal justice system and their relationships with the communities they're meant to serve. In return, these policies do virtually nothing to prevent drugs from entering the US or other countries, nor to mitigate problematic drug use and related harms. Rather, they produce harms. My organization, the Law Enforcement Action Partnership, of who I am the executive director, has long stated our drug policy contributes to racism, violence, human rights abuses, addiction, disease, and death across the globe. The US public increasingly knows this. Even years ago, polls by Pew and Rasmussen showed declining public support for our drug policies and widespread belief that the drug war is a failure. Yet majority opinion holds depressingly little sway over many criminal justice professionals, prevailing belief that drug use is a morally flawed choice. At the same time, for all the obstacles and reactionary elements that remain, there's been tremendous shift among many criminal justice professionals in the last decade, and recognizing that criminalization has not solved America's nor the globe's drug-related problems. Many examples of reform are incomplete and imperfect, yet still represent progress. Evidence includes crops of reform DAs, a small downtick in nationwide incarceration, diversion programs, a nationwide law enforcement call for medication-assisted treatments in jails and prisons, and many incremental legislative reforms. Law enforcement professionals here and abroad, not enough, but a growing minority, and I would say we're increasing into a majority, have been calling for safe consumption sites, syringe exchange programs, naloxone distribution to both the public and the police, for access to methadone and Suboxone, for pre-booking diversion programs like LEAD, for drug treatment on demand, Good Samaritan laws, drug checking services, for a safe drug supply, and for the decriminalization of all drugs. And for the first time, Congress has approved a $30 million appropriation for harm reduction services in our country. This panel will explore some of the old and the new directions in drug policy and how they have made and can make crucial differences to people's lives. This includes how the impact of COVID and the death of George Floyd is creating opportunities to move the policing of people who use drugs towards co-producing community health and safety. I apologize to everyone. My name is Diane Goldstein. I'm a 20+ year career law enforcement professional and currently the executive director of LEAD. And with that, I'd like to introduce retired police chief Brendan Cox, who is now the director of policing strategy for the LEAD National Support Bureau. And Chief, can you discuss the evolution of LEAD and its impact on reducing the footprint of the criminal justice system?
Absolutely. Thanks, Diane. It's great to be on the panel. Great set of folks to be on with. Humbled to be with everybody. So LEAD, Law Enforcement Assisted Diversion, started back in 2011 in Seattle, and started because of racial disparities within the criminal justice system, specifically around drug arrests and specifically around policing and how we try to deal with things in the criminal justice system that just simply can't be dealt with, around those prolific offenders that have those unmet behavioral health needs, folks living in poverty, folks that are homeless, that we've tried to deal with through punishment and mandatory treatment that just hasn't worked. So about removing those folks from the criminal legal system and instead having long-term street-based case management based on a harm reduction platform of realizing that through relationships, through addressing trauma, through addressing underlying needs, getting people housing first, doing things that actually take care of the person and stop worrying about whether or not somebody's using a drug the moral failing issue, that we can actually do better. We can actually make more of an impact. And when LEAD started, LEAD was a pre-arrest, pre-booking diversion. It was about having the officer at point of crime have an option to take somebody and rather than arrest them, give them an option to say, hey, would you like help tonight rather than me arresting you? If that person said yes, call a case manager, meet that case manager and do a warm handoff and turn that person over to that case manager and step back and let the case manager do what they needed to do to build that relationship and really start a long-term change, recognizing the stages of change and that folks make incremental changes. And from there, it grew to the next step of the social contact referral, which it meant that there was a recognition that we didn't have to wait until somebody committed a crime, that we could get somebody the help before that crime was committed, recognizing that officers knew a lot of the folks in the community that had that criminogenic profile, that had those unmet behavioral health needs, that could use that help. And also that people in the community knew those folks too, and that people from the community could make that referral in, but that we still kept police as the gatekeepers, that police were the ones that said yes or no, that they were the ones that wind up ultimately saying, like, this is the person we're going to go ahead and give access to leave for. And that worked really well for the last 10 years. And that's been what we've been doing around the country and actually now internationally. And it has worked well. And it's a good way to change policing. And it's a good way to change how we look at addressing these issues that should not be in the criminal legal system. But with the pandemic, and certainly with the murder of George Floyd, something that we wanted to be moving all along, because LEAD was not meant to be here forever, and LEAD was meant to be changing, was now the transformation of let everyone advance with dignity. So a community component to LEAD. This recognition that we can take direct referrals from community members to help really transform how we're providing those long-term street-based case management services to individuals that are in need, because community members are looking for that platform to be able to get folks services, because of course our business members, our neighborhood leaders, folks living in the community, they know the folks that need help as well. And they actually are looking for an alternative. They don't want to call 911 because somebody is sleeping in front of the doorway to the store when they come in the morning to unlock the door. They don't want to call the police when the neighborhood, somebody from the neighborhood comes in and steals. They recognize that they know there's a better alternative out there. They want to make sure folks get help. You know, we talk to people over and over again, and we talk about whether or not somebody should go to jail or should get help. And at the end of the day, most people want people to get help. So we've created Let Everyone Advance with Dignity, which really allows the community to make that direct call, where we can get case managers that can go out and can ultimately get the person into LEAD and get case management services. And the key to this really is the fact that we're giving somebody that in a different pathway in, but we're also then alleviating some of the costs for service for police. And at the same time, because of the way LEAD is set up and because we have communication with all of the law enforcement partners, police and prosecution, we're still having those communications. So we're still allowing for the police and prosecution to know, hey, Brendan Cox is in LEAD. This is how he came in and this is how he's doing. So that way we don't make negative decisions in another arena that are going to impact the person that we now have in LEAD. Because we also know that if we make those bad decisions and we hurt somebody by putting them in jail for a minor crime, by arresting them for a minor crime, we may take away housing options. We may take away Medicaid options. We may take them away from that slot that they're waiting on for a methadone slot, because we know that we have far too few services in our communities and we have to put people on waiting lists and they have to wait to get on something. And if all of a sudden they're not there for that slot, guess what happens? They lose that slot. So we know we have a lot of work to do. We need to change the way we look at things in our communities, but this is a really good option. And I just want to say that the reason why LEAD has to exist and the reason why we all do what we do here on this panel is really because our legislative bodies don't act quickly enough. So many of our leaders in our jurisdictions around the country have had to make changes and say, you know what, we can't wait till the laws change, so we're going to make our changes now. What I think we would all hope is that our laws would finally catch up and realize that we're all here saying we need to do things differently. And until our legislative bodies kind of catch up and help us out, we're going to be stuck trying to find alternative solutions on our own. The legislative bodies can all talk about doing a good thing, but they don't seem to want to really do it. So I'm going to get too political for a second, Diana. I apologize. But in the US, cannabis, which seems pretty clear, should be legal for recreational and medical purposes, is still not, depending on what state you're in, including New York, which is supposed to be a liberal bastion, but it's not recreational purposes. And we've seen recently, and we know that on a federal level, we still have it as a Schedule I drug. So we've seen recently folks that can't work in the White House because they admitted, God forbid, to using cannabis earlier in life. Well, let's break the record, okay? I was a chief of police, and when I was a kid, well, guess what? So stop all the nonsense. This is ridiculous. We need to get our legislative bodies to catch up to where we are. So, you know, that's where I think we are, Diane. We need to just make sure that we can continue to grow and we continue to transform, and we can't stand still. We have to make sure that we continue to do that.
Thank you very much, Brendan. Chief Mike Sir, are you there?
Looping back in, and thanks, Diane, and thanks, Brendan, for that. So I just thought I'd give the Canadian perspective here, if you don't mind, for a few minutes. So just to give you some background. So for my 31 years as a police officer, I'm currently the chief just about an hour outside of Vancouver. And I've worked both on, you know, the downtown east side and some of our most marginalized people who use drugs, all the way to, you know, organized crime. And it really, over that time, has really taught me just that we needed to look at different approaches, really looking at how to support people who are using drugs, while at the same time trying to reduce the demand, which is, I think everyone here from law enforcement knows, is something that we have always been challenged to do. So moving forward, I'm on the Canadian Association of Chiefs of Police. I'm the co-chair of the Drug Advisory Committee. And in 2016, Canada, like the US and other places in the world, was really hit by the opioid crisis. And the amount of deaths we saw was absolutely significant and devastating on a daily basis. And here in British Columbia, where I'm from, a population of 5 million people, last year, for example, we had 1,726 people die from an overdose. But that doesn't even speak to the numbers when we talk about, you know, how many times a day we're going and responding with naloxone and other tools to save people's lives. So we really, you know, I think it really woke us all up across Canada that we had to look at this differently. We had to come up with different approaches. From the Canadian Association of Chiefs of Police, tons of credit. In March of 2018, our committee asked the board if we could stand up a special purpose committee to start studying decriminalization and how that would look on public safety and how as we police leaders can take a position on that. Like I said, I mean, we did this. There's, you know, everywhere from politicians to key doctors across the country were really advocating that we needed to look at different approaches. We also knew that criminalization of simple possession was disproportionately, you know, impacting our racialized communities, and wanted to look at just how that we can be better supportive of everyone. And we also thought there was a better approach. So we stood up a committee of experts from across the country, from a bunch of our different committees to really look and do a fairly comprehensive report on this. We actually sent police leaders to 10 different countries around the world to look at different approaches and models, which included Portugal. What was interesting is Portugal said, you know, don't copy us, but learn from us. And I think that was a very valuable tool. I was also interested to know that Portugal said we were actually the first law enforcement agency to send from any country to send over a delegation to kind of go over and study their approach. What ended up happening is we put out our final report called Decriminalization of Simple Possession of Illicit Drugs, exploring the impacts on public safety and policing. And we did a press release on July 9th, and it really received national attention. And I think it really caught many people off guard that the Chiefs of Canada would be bold enough to put out a position that would call for decriminalization. And our key statements in that report was that people or persons who use drugs, that it should be a public health and a social priority and not a criminal priority, that we endorse alternatives to criminal sanctions for simple possession. We did say that we do not in any way support the legalization of drugs, and that we remain committed to disrupting organized crime and those who produce, import, and distribute the illegal and poisonous drugs on our streets. But, you know, I think the statement that caught a lot of people was the fact that it should be a public health, simple possession of public health and a social priority. That really started, I think, a wave of conversation in our country, which was good. A lot of dialogue and a lot of discussion. Our public prosecution service, which prosecutes federal offenses like simple possession of drugs, came out with a directive a couple months later. in which they said they would not prosecute any simple possession charges for drugs across our country unless there was a significant impact on public safety, or impacting youth, or impacting our Indigenous communities, or involved impaired driving were some of the examples. So really, in a sense, we de facto decriminalized all drug possession, shortly after our report came out, because quite frankly, our prosecution system is not going to accept any charges. From a chief's perspective, we were a little concerned by that, only in the sense that we're building the plane while we're flying it. In our sense, we need to build the infrastructure and the model and the system in place to support individuals, and not just simply decriminalizing and thinking that's the panacea. And as an example, in Vancouver, we're a very liberal province, and I would argue we've de facto decriminalized drugs here for the last 10 years. Vancouver, a big city here, has had 15 charges for simple possession last year, in 2019, I should say, pre-COVID. In Abbotsford, we had 8. So we're not charging people, but we have one of the worst problems in all of Canada. And in essence, I would say it's because we haven't built that system or that model that helps support people. Portugal is a little bit different. It's a very small country, and Canada is a very diverse and big country. So we have to develop those wraparound services and supports for individuals. And I think that that's a mistake that you sometimes hear, is that, it's on-demand treatment, or it's opioid-assisted or opioid agonist therapy, or peer support. But what I would argue is there's not one approach that's going to fit or serve everybody and where they are in that point in their life. The other thing is, for us, it's very important, is we need to also support families, and we need to support a community. And has said, how do we support a community that is being impacted by somebody whose drug use is impacting negatively or harming a community? And how do we do that in a respectful and healthy way? How do we also support, families who are really struggling? And we, as police officers, we get a lot of calls. We also had our federal government come out just briefly with Bill C-22, which is openly calling for diversion, for police to look at all diversionary models as opposed to criminal charges. So it was sort of decrim light that came out, but it certainly is again taking it to that next level. And I think more discussions will come. One of the things from the Canadian Chiefs that we also asked was that we needed to build a made in Canada approach. And we asked that they stand up, the federal government stand up a task force or a committee of experts to look at decriminalization and include all the stakeholders, from people with lived and living experience to health, to academics and police and health. And we bring in a wide range of opinions and advice. And I'm happy to report that on March 10th, that committee was in fact stood up in Canada. It has 4 co-chairs. I'm fortunate to be one of those co-chairs. And the mandate of this committee is to look at the Canadian drugs and substances strategy and to provide recommendations for that, and also to assess potential alternatives to criminal sanctions for simple possession. And we are a very short timeline, but in May, to provide a report to Health Canada, which gives our recommendations. So you can see, I guess, in all that Canada is really very engaged in this conversation and dialogue, but we need to do it right. I say very frequently that we have one chance the first time to do it right, and we got to make sure we do our research. We need to include our provinces, our territories. We have very northern regions that don't have the same supports that other regions do, like some of our bigger cities. Be very mindful of our Indigenous communities, which are impacted, or our Black communities. But I do believe that there is a pathway here, and I think a lot more discussions coming on this. But yeah, lots happening in Canada. I would say stay tuned, and I think you'll hear a lot more in the coming months.
Thank you very much, Chief. This is one of the big paradigm shifts here in the United States that I think our partners to the north and over from the UK and in Europe have really helped us to look at how we redefine policing. And for so long, we've just made law enforcement and the criminal justice system the expert in policing instead of a much more inclusive community health and safety. And so, as I continue to do my work in LEAP, this is the push and the models that we're looking at is you have to have all the stakeholders at the table, and it includes people with lived experiences and representatives of every community, and most importantly, the communities that we've harmed. I'd like to introduce very brief Suzanne Sharkey, who's the co-executive director and spokesperson for our United Kingdom LEAP branch. And she's going to talk about how in the UK in particular, what we're seeing is pushing reform. Interesting enough, is law enforcement itself.
Hi, yeah, I'm, as Diane said, Suzanne Sharkey, and I'm just sort of briefly in the time I've got, give you a couple of examples of the changes that are occurring in the UK amongst police and schemes that are being ran to help with the solutions. You know, I have to start off that, you know, drug-related deaths in the UK combined are the highest in Western Europe. You know, 15 people a day die. And people who use drugs, especially those who use problematically, are the most stigmatised and marginalised in our society. And unfortunately, all too often, they end up in the criminal justice system. I'll just intersect there by saying I was a police officer, I'm ex-police officer. I'm also in long-term recovery from alcohol and other drugs and being both sides of the police cell. So I have viewpoints from both sides, if you like. So in England and Wales, we have 43 police forces, and at the moment, about 10 of those have police-led pre-court diversion schemes, and at the moment, 3 are developing those. These vary considerably on what diversion is, and you know, we can ask, what do they actually mean by diversion? Because even though we are a very small country, because our police forces are divided into 43, amongst those there can be quite extremes of what they believe and see diversion to be, and that itself can be an issue. So for me, one of the examples that stands out, which I would say is a true diversion, has been used in Thames Valley. This was actually initiated by Chief Inspector Jason Q, and basically driven by the increase he saw in drug-related deaths in his command area. It's actually one of the largest police forces in England and Wales. Its population's 2.3 million. And the base of the scheme is to change drug possession into a health outcome rather than an incriminating police encounter. The police found, so that means that the people actually found in possession of illicit substances do not require arrest or criminalisation, and it is seen that these measures are not necessarily appropriate response to the situation they're faced. So the role of the police officer is to create a non-stigmatised, non-punitive way for people to have an assessment about their drug use in order to make a healthy, positive change in their life. So they basically apply decriminalisation by de facto. And the aim is it's like a gateway of support, and whatever that looks like. So as I said, the role of the police officer isn't to further criminalise an individual. The deterrent itself has failed because by the very nature of the individual being found in possession means that the drug laws in place to stop the supply and demand have failed already. So the role becomes a health issue and how a person can be helped with the situation. The response is a direct individual assessment, education, and if necessary, treatment. And a community resolution is applied in the case of adults. So there's no police follow-up, only a health one. So anyone found in possession is basically sent to the drug services. In reality on the ground, what that means for a certain police officer, it requires 10-15 minutes of police time and the cooperation of individuals. It's simply used on an app and a device. There's no arrest, no admission of guilt. So it simply turns into what could be an incriminating encounter and possibly devastating consequences for a person into a positive health outcome. This also frees up obviously valuable time for frontline officers, as the person stopped doesn't need to be arrested, taken into custody and so forth. And the design of the intervention is left up to the health services. It's actually what that individual needs and meeting that person where they're at. Importantly, this scheme doesn't have a desired set of outcomes, so there's no targets made or demands made by people up above. It's simply helping the communities that they serve. And the results have shown that 88% of young people under the age of 18 have engaged with the scheme and completed attendance. A staggering 95% of all adults excuse me, that received a deferred summons completed the course. And that again is simply, it requires 2 online sessions and follow-up if required. And the diversion's been running for a couple of years now, and each year it's led to 4,500 people avoiding a criminal record. The diversion scheme can be replicated anywhere as well. That's the beauty of it in any of the force areas. But also it's been adapted already to be used in schools. So when we're looking at childhood trauma and indications where we have students that are found in possession and are just face expulsion, that isn't necessarily the case. And also transfers into sex work. So for me, it's truly a diversion because at that point on the street, they are completely diverted into the health system. And at the opposite end of the scale of that is a scheme that's been run in Middlesbrough, which is in the east of England, where I'm from. And I say that's the other end of it because this is heroin-assisted treatment. Now, Middlesbrough is in the northeast of England. It has the highest drug-related deaths in England and Wales, also a high area of social deprivation and unemployment. And we know the correlations between that and drug-related deaths. And it's the first heroin-assisted treatment to be operating in the UK. Now, the start of that creation was actually back in 2017, and I have to mention Daniel Ahmed of Foundations Medical Practice. He started these conversations. The actual system itself, where clients were receiving heroin-assisted treatment, started in October 2019. And basically, again, the initial conversation was about people are dying. You know, the actual data shows in Middlesbrough that more people die from drug-related deaths than killed in a car crash. And what he did, you know, his background is in health, and he looked at service systems that were in place to help problematic substance use. And basically, the way people were treated was in fact inhumane, and it set people up to fail who they were supposed to help by the very nature of problematic substance use and the complexities around individuals. The systems just set them up to fail. And also driven by the belief that people who use substances problematically get a fair shot at the right treatment, you know, a basic human rights principle, and they just don't get that. And that is a problem, that the right treatment for the person where they're at is not applied. So knowing that there was evidence there for an intervention like heroin-assisted treatment, you know, like Mike said in Canada, he visited Canada, went to Denmark, it was frustrating that he couldn't do that where he was, or why couldn't he? So, you know, driven by passion and wanting change, he looked at the two things that can make a difference, which was drug consumption rooms and heroin-assisted treatment. And heroin-assisted treatment was actually the hardest of the two to set up because it's complicated. You know, you have responsibility for managing a clinic, getting the substances, the licenses, the finance, the sourcing, and issuing to individuals in a clinical setting. Whilst the drug consumption rooms, they're about providing a safe environment for people to take substances with you know, the right amount of care for the individuals. It's not easy to set one up in the UK because of the legal system. You know, they are illegal in the UK. So the scheme was launched in 2019, and fundamentally it was supported and funded by the Cleveland's Police Crime Commissioner and the Cleveland Police Force. And what they're actually doing now in the last year, they're using money seized from criminals under the Proceeds of Crime Act to help fund the second year of it running. It's funded and it runs 15 people at any one time. And again, really importantly, like it's already been said, it's a multi-agency approach. But there's also a selection criteria used because, you know, it was only available to 15 people. So looking at crime information, those on prolific offenders, those in and out of hospital, and where previous treatments had not worked, and those that were chronic injection users. And these individuals were approached and offered the opportunity to participate. And actually, to start with, it wasn't an easy sell because they themselves were sort of dubious about what that actually involved. And we have to remember, you know, heroin-assisted treatment isn't a soft option for participants. It's a really structured program. So twice a day, every day, rain, hail, snow, whatever, these people have to get to the clinic to get their heroin-assisted treatment. You know, so they themselves have to have a massive commitment to change a very chaotic way of life to a very strict one, and that in itself can pose problems. But they have, and they've done so. And it's shown dramatic changes in individuals' lives. You know, an analysis that was done over a 30-week period of, it was actually 6 participants on the scheme, revealed that those 6 people had committed 541 detected crimes at an estimated cost to victims and the public of 2.1 million previously. And from starting that treatment, their combined crime total fell to 3 lower offences, which is incredible. That obviously has had a knock-on effect, and the impact on the local community in terms of reduction of crime, the increased social stability, and a reduction in antisocial behaviour was huge. And the pilot continues, but like these, as a pilot, funding is always an issue. And last year, in 2020,
Suzanne?
Yeah?
Let's leave some of this for the question and answers. I need to get Brandon on also.
Okay.
Sorry about that. It's our panel's just for 55 minutes.
Okay.
I'll come back in. No problem. Don't worry about it. Brandon, I know that your research this last year has been focused a lot on how we can create opportunities for change around COVID-19, and in particular, how, if you could discuss how, you know, the intersection of COVID-19 and the movement for Black lives after the George Floyd murder has really created these opportunities, and how you see us capturing those, and then we'll open it up to question and answer.
Yeah, sure. Thank you. And it's great to be a part of this panel. I think, you know, to listen to the range of opinions from North America to Canada to across the pond is inspiring. The problem is, I bet I can't see the 50 or 40 something participants, but I bet I'd know all but 2 or 3 of them as the same people who are involved in these issues. And I think we need to get the word out more widely. You know, I guess I'd start by offering an observation, and then I'll bring it right into the questions you asked, which is, when I first became the chief of police of Burlington, my mayor said, listen, we're a city with a opioid crisis. We don't have a Department of Health. You're a chief of police with, like, you know, a lot of energy. You came to this job to make a difference. You moved all the way up from New York City for it. I need you to find a solution to the opioid crisis here, but I don't want it to be a police solution. So I went and I talked to folks at Johns Hopkins, at University of Pennsylvania, leading researchers. I met up with folks like Brendan, and people said to me, listen, we have a luxury here that we don't have with other problems. We have the answer, right? There are very, very effective medicines that have long-term efficacious effects on addiction. They reduce overdose, they reduce the amount of crime people commit. The people who are given these medicines with the right access have relatively lower rates of relapse versus other things. And I went back to my mayor and I said, listen, the answer is just this, you've heard of methadone. There's this other thing called buprenorphine. We need to give it to people and it'll save lives and reduce overdose. And he said, you're wrong. If it was that simple, we'd be doing it. I know you're a cop that I asked to fight an overdose crisis using public health, but it can't just be as simple as we are not giving adequate access to medicine. And I went back, you know, and I said to the researchers and scientists, doctors, and I said, is this true? And they said, no, the sad part is that, you know, no medicine alone is a silver bullet. We need wraparound services and a lot of the other things folks have touched on, but it really is that we just don't have adequate access to treatment-based medicine. And I realized at that moment, it wasn't the science, right? With methamphetamines, there's still a huge scientific problem. With the pandemic, there was a race against time to solve a scientific problem. Buprenorphine has been approved for treatment for opioid use disorder since 2000, and it took years just to get it there, but for 20 years it's been approved. Methadone since I believe the 50s or 60s, when Dr. Creek discovered it at Rockefeller. And so it's a question of the systems rather than the science. So the reason why I bring that up, Diane, is because what COVID has done and what the movement for Black Lives has done have provided one an exogenous and one an endogenous shock to the systems, right? So at the onset of COVID, knowing that there'd be vast disruptions to treatment, what SAMHSA did in the US was say, you can induct people into treatment by telemedicine. You can give people 30 days of take-home dosing for buprenorphine or methadone if they're stable. A lot of the regulatory apparatus around these medicines that existed was just thrown out the window in the name of the pandemic. And I said to a researcher, Leo Boletsky, I said, we should evaluate this. And he said, that's a little backwards. He said that the onus, I wrote something where I said, we should evaluate these changes to make sure that we can keep them. And what Leo said very astutely was, no, the onus should be on other people to evaluate them to make it go back to the old ways, because these regulations that we have in place now were regulations that were not based in evidence, that were not based on the best solutions for saving lives, and the onus should be on the people that wanted to go back to the old ways. So, and then now with the movement for Black Lives, you know, Brendan Cox, it's always Brandon and Brendan on the panels here. Brendan talked about how LEAD was begun to address very racially disparate outcomes in drug enforcement, and that's true, right? And I think that, you know, to solve the problem of systemic racism in America and in policing is a very, very long road to hoe. It will not happen soon, but one of the low-hanging fruit is addiction and drug policy and treatment. And I think that we could talk more about it, but the most incisive and the most lasting and the most meaningful changes that we can get now can start with things like drug policy and race, right? Because if you look at the differential in sentencing and charging for crack cocaine versus powdered cocaine, if you look at how analgesic pill addiction was treated differently than injection addiction and how that divides by race, you can see tremendous disparities. But I'll close by saying, before we go to the questions, what's in front of us right now is the opportunity to take advantage of the rapid deregulation that the pandemic led to in access to addiction treatment that could be perpetuated once we get our bearings to save lives. And that as we go about seeking to ameliorate our problems with racism in so many corners of public administration and policing, we have an opportunity to make quicker progress, I think, in addiction and drug policy than a lot of other aspects by very astutely following up on the you know, kind of the reforms that Brendan and Chief Sir and Suzanne talked about.
Great, thank you very much, Chief. We have a great question in the question and answer, and this is from Isabel Theron. Listening with attention from Australia, thank you for being here and enjoying the panel so far. About the new advisory board, this is for you, Chief Sir. She says she'd be really interested to know what other forms of engagement happen as part of its activities other than community representation on that advisory board. And are there regular consultations with the community, focus groups, listening sessions, etc.?
Yeah, thanks, Dan, and thanks. That's a very good question. So just a little bit more on that expert task force. So there's 4 co-chairs and a wide diversity in the 4 co-chairs, which, you know, academic, indigenous, background, and persons with living experience as part of the co-chairs. So we all bring a kind of a different perspective, but we actually work really well together and we really collaborate on our discussion. Our task force, then we have the task force, which is, I think it's now 14 individuals. And again, a wide variety of experiences. And then has a committee. We've decided on, you know, a group of where we think we have gaps and we need to learn more, and bringing in different, stakeholders from across Canada who can actually do short presentations and speak to us so that we can be better informed in order to make, you know, good informed, policy recommendations. So we are collaborating with everybody. And like I said, if anybody in our team or task force sees any gaps, we can reach out and ask for a presentation to get a better perspective.
Great. Let's see. One of the I see that there's a raised hand from out in the audience, but I can't see who it is. Tamia, can you take a look? So I want to make certain we get their questions answered, and you can put us on the gallery view if needed. But Suzanne, I wanted to go back. You had said something interesting, and I'm sorry, just trying to keep everything timely because one of the last panels, things got cut off. Mitt's question at the end is you were talking about the success of HAT. And as I recall, my history is the United Kingdom years ago had one of the longest successful heroin assisted treatment programs. And then they ended it. And now it looks like we're finally the process of restarting this. And so this one program has been very successful. Thinking about your stats, right? And I'll let you a couple minutes to finish off.
No, I mean, just basically sort of the end of it was that, you know, because of the success of it and the people taking part have overwhelmingly improved their lives. There's been an opiate scrutiny panel set up by local councils. So basically, these schemes that have been put in place and have shown such success, you know, as we see all around the world, they work. That scrutiny panel has been looking into the scheme and benefits and made recommendations for a drug consumption room. The area, Middlesbrough, they want it. They've got the systems in place to put it. But a bit like Brandon said earlier, is that the Home Office and the public health don't have an appetite to change this. You know, it's still illegal. They don't want to change that or be open to them or trial them. You know, even though the evidence shows that they save lives of the most marginalised and vulnerable people in society and, you know, cause a lot of criminal activities in the area. And, you know, that's what we need in the end is, you know, we're very lucky that it's going in Middlesbrough, but we need more and more of these, and we need them all over the UK. But again, it's back to that political bit of, you know, the powers that have the powers to change it still, even with all the evidence, won't change it.
Yep. Thank you very much, Suzanne. Tamia, I think it was Barry Getz that had a question and was raising his hand. You can let him in.
So that he can participate if he wants to.
Yeah.
I was waiting for Suzanne to finish up.
So can I ask the question?
Yeah.
Go for it.
Okay, this is for Suzanne. I was interested in what you were saying about more of a public health approach through the UK programs, at least the ones you're involved in. I had done some research there in 2019 before the pandemic, and Thames Valley, and I think you mentioned Jason Q and West Midlands, and then also in Durham. And my impression was that there was frustration because the police felt that there was no endpoint, that they had no assurance that that after intervention that there was a way to measure whether somebody was not returning to use, and that they wanted to have, I think they called it in Durham, they called it the sword of Damocles to make sure that there's a point where you know that there's no more options and you haven't taken advantage. I know we're short here, so could you speak to that? Because that was a little confusing to me.
I mean, it is, but it is one of these things that we all want things that we can measure, and we all want a clear point of from the problematic substance use, you know, recovery. Oh, you know, they're fine, they're cured, and they're over it, and it just doesn't work like that. It's a really difficult thing to measure. You know, what I'd say is it's simple, like if you refer to the heroin assisted treatment in Middlesbrough, where the crime has been reduced significantly because they have been directly helping the ones that have caused the crime. The one in Durham, Checkpoint, it has had issues with being able to measure that. And like you said, I have no answer for you basically because it is such a very difficult thing to measure. Thames Valley, they've done it for 2 years, and I think they've got the studies coming out shortly by the university that's helping them with the research of what's happened there, and I don't know what that's going to bring in. So that is an issue because we all like results and say, oh, this works, but we can see that it's just, what I'd say is that these schemes, they save lives.
And Suzanne, could you just tell me what agency you're with? I'm sorry, just real quickly.
So, yeah, UK LEAP, Law Enforcement Action Partnership.
Okay, thanks.
So
Diane, can I just-
Brandon. Go ahead, Brendan, jump in, and then Brandon, you can answer that one question too.
Sorry. So I think that's also though us looking at the wrong measure. What the measure we should be looking at is whether or not crime went down. That should be our only issue as police. We shouldn't be worrying about whether or not somebody's continuing to use. That's a health issue. And if crime is down, we shouldn't worry about whether or not somebody's using. Yeah, is the human being in me worried or not whether or not that person's going to be healthy? Absolutely. But at the end of the day, I'm not a doctor. I'm a cop. That's for a doctor to worry about. The human being in me is concerned about that individual, but the measure I should be worried about as the chief of police is whether or not crime went down.
Great. And Brandon, I think that rolls right into your answer over here that I'm looking online in the chat.
Yeah, thanks. I think that I agree with Brendan that the police need to pick the right endpoints. The only subtle difference I'd say is in addition to crime going down, police have a stake in doing what they can to lower accidental death, right? And to lower morbidity and mortality. So it's not, is the person optimally healthy, or I'm concerned that there's the statute out there that's being broken, where we want to know, is our community resilient? Is our community safe? And are the people in our community facing lower rather than higher risks of morbidity and mortality, of injury, right? Whether it's roadway safety or overdose. So we have to get to the true endpoints of public safety. And the true endpoints are not the amount of kilos seized, not the number of guns taken off the street, not the number of drug arrests made. The supply side strategy is a failure because it's a tenuous causal link to better health. And we've never even affected the price of drugs with a lot of supply side interventions. So I'll put a link there's an article that myself and a few colleagues wrote that just came out as part of this conference that talks about just this, about getting the endpoint problem right. And the one thing I'll say with an extra minute, maybe to make the point, is that even if we were to really decriminalize and regulate drugs, if we were to follow Oregon's lead or, follow the lead that they're taking up in Canada, there's still going to be a lot of risk behaviors that people engage in when addiction starts to take its toll. The police will still be in the business of responding to people who use drugs, not because of the drug possession or the drug use, but because of, some of the behaviors that occur when drug use goes awry. And so we're still going to have to teach police, in my opinion anyway, what the true endpoints are of police work, whether someone is burglarizing a home or stealing from cars or committing theft or fraud, or there's homelessness or domestic violence issues that come with drug use. The cop has to be thinking, what is the health goal of what I'm doing? And it's to get the person, not to get the burglar, but to get the person out of the situation that leads to burglaries, because it also could lead to overdose. And so it really matters that we retool the ultimate goals of policing in doing so.
Absolutely. So Tracy Price had a great kind of comment, not more of a question, that I think that's important. And Tracy, if you want to pipe in, but what I read your comment is we also need to look at people's lived experience, that if they're making positive changes, it's, I think, like both Suzanne, Brandon, and Brendan said, it really isn't a policing issue. We need to let other structures solve the systemic root cause, and then we can deal with the crime issue. And there's multiple ways of solving that.
Exactly as you've said there, Diane. Just I feel that we often talk about these interventions and we talk about measuring success, and I think we do get sometimes tied up in talking about criminogenic needs, and we start to think about reoffending, but sometimes it's the small incremental changes that make the biggest difference to someone's life. And that might not be, as Brendan says, that might not be about reducing drug use specifically. That can sometimes be about the steps that people take towards changing their lives so that life feels better, harms are reduced, and people feel ready to address drug use in time. Sometimes it's that really human stuff. Sometimes it's interactional, sometimes it's relationships.
Anyone want to comment before we close down? I've been told that we could probably go over about 5 minutes. If there's any other questions as well, we'll try to get them.
I just wanted to say that point that I guess Tracy just made is a really good one. And that's that we fail to take seriously the lived experience of people, especially when treatment we have a very rigid definition of treatment, a very rigid definition of recovery. We have people saying, no, there are a lot of different ways I can find myself under treatment or in recovery that would improve my quality of life, help me keep my family together, my job. And I think we need to start taking those more seriously. And if we do, we'll see that like a lot of the very rigid ways we administer methadone and buprenorphine, a lot of the ways we say you're in compliance or out of compliance, we'd have to start doing away with a lot of that, but we'd end up helping people more and saving more lives. Thank you.
No, absolutely. Anyone else have raised hands or questions? And if not, I'll give everyone just, a few seconds just to close out on their thoughts and appreciate the audience. So I'll start with Chief Sir.
Yeah, no, I really appreciate being part of this. And I saw the question in the comments just about, the police, and the buy-in. And, one of the challenges we have, and that's why I don't know what that model looks like here in Canada, but we do need to come up with a decriminalized model that really works for us and works for individuals, but also has to work for families and community. Because, what the challenge is and where we lose the buy-in from the community, from the police and from families is when we get that phone call and there's no supports and we can't help an individual, or we get that phone call from the shop owner who's just had their place, broken into 5 times by a person who is doing a survival crime to support their addiction. We want, and we're actually seeing in Vancouver, which is a very liberal city, for example, where some of the communities starting to push back because they're seeing their community's been so impacted without supports really being in place. So I think we're all on the same page. We 100%, this needs to be person-centric. We need to help and support individuals, but also there are some individuals who we have to have a system for who just, where we have to help guide them in this path that is also going to make sure that, we can take care of our communities as well, because this is a really big issue. And I don't know what that model looks like yet. I hope this task force will help us kind of come up with some recommendations, because Portugal and the dissuasion committees isn't exactly the perfect model for us. But what that looks like for us, we'll have to figure that out. But thank you for the conversation. It was excellent.
Thanks, Chief. Brendan.
Yeah, no, I think Chief Sir is right. I mean, it's not an easy solution. I think one of the things is we always look at and say the criminal legal system's broken. And while I agree with that, I also think the services is broken. I know that here in my hometown, short of the new pandemic rules, if I had to go wait in line 6 times a week to get methadone, I'd fall right out. I can barely get my own medication if it wasn't for my wife. So at the end of the day, if we don't fix all those other systems, we can't help people out to be able to ultimately get through those systems that they need the help with. I just know that we need to stop looking at illicit drug use as a moral failure, which I think, the great thing about this panel is everybody recognizes that and looks at this the same, which is part of that paradigm shift and part of the reason why I think all do the work we do is because we want to actually have everyone stop looking at it that way, recognizing that punishment and coercion, they're not the answer. We need to change what we're doing. So thanks. I appreciate being on this.
Thanks, Brendan. Suzanne?
Yeah, just, it takes courage for your police officers in position to stand up and try and change the systems, and we need more of that. We need more police saying our systems are broken, our drug policies do not work, and look through the eyes of empathy and compassion, because problematic substance use affects everybody. Everybody in some shape or form will be affected by it or know somebody, and and listen to the communities. There's a lot of wisdom in the communities that everybody can learn from as well. And I suppose ultimately, from my perspective is, dead people don't get the opportunity to recover.
Absolutely. Thanks, Suzanne. Brandon, it's yours, and then I'll just briefly thank everyone.
Yikes. No, I think that it's inspiring to hear people thinking so clearly about what has to be done. And I just want to remind folks that police don't come from Police Island. They come from in and around our communities. And so a lot of the slowness that we have in progress is not because the police are imposing it, but because it's a product of where police come from. And as much as everybody here is thinking very evidence-based and forward-thinking about these solutions, right now in the West Virginia state legislature, there's a move to criminalize syringes and shut down all of their needle exchanges. And I talked to some local police officers in the Midwest, and they say, I don't feel comfortable not making an arrest for drug use because I know my public expects it of me. So I think that like we need to continue this, amplify our voices, and don't forget that like we're talking about not just problems in police culture, but problems in the American and Western attitude towards drugs.
Absolutely. And with that, I'd like to thank everyone here who attended. And I know that you have the ability to post more questions on the Hoover app, and we will take a look at that. You know, this is a hard conversation, and we need to continue to push forward that conversation. My organization started out as a single focus on drug policy, where we talked about legalizing all drugs back in 2002. And policy work is going to be the hardest of this. You know, Brandon's right. In California, where I'm from, I'm testifying against an overdose bill that a politician wants to basically charge people with manslaughter and have people admonished that when they plead guilty to possession of drugs, that this in fact can happen to them in the future. So it's going to literally take all of us to blow up this failed drug policy, and we'll continue to do the work together day in and day out. Thank you very much, Tamia, for helping us moderate this. And I know we're about to get kicked off, so we'll see everyone later.
Have a good day, everybody.
Thank you, everybody. Be safe out there. Have a great conference.